Imagine three people arrive at a hospital simultaneously, one with a stubbed toe, one having a silent heart attack, and a car crash victim. If a hospital operated like a retail store or a bank, the person with the stubbed toe might be seen first simply because they walked through the door a few seconds earlier. Applying a first-come, first-served queuing model to medical emergencies would guarantee that people die while waiting in line. To survive this severe operational unpredictability, hospitals use a specific countermeasure known as triage. This diagram shows an abstract funnel model of how triage actually works. It is a strict prioritization engine designed to ignore your arrival time completely, evaluating incoming patients and separating them into specific priority lanes based purely on their immediate clinical need. Without a mechanism to ruthlessly sort patients by the severity of their condition, the emergency department would buckle under its own volume, turning a busy Friday night waiting room into a mass casualty event. The process starts the moment a patient walks in. A specialized triage nurse or paramedic performs a rapid, face-to-face physical evaluation. Here is a clinical decision matrix showing the first set of data points collected during that evaluation. The staff records exact quantitative vital signs, tracking metrics like the patient's heart rate, blood pressure, and oxygen saturation. But raw numbers only tell part of the story, so the matrix processes those vitals against a qualitative data point called the chief complaint, the primary reason the patient is there, whether it's severe chest pain or a minor cut. Combined, these inputs generate a definitive priority tier. When the system detects an immediate threat to life, such as a cardiac arrest, normal intake procedures vanish. The patient is routed through a bypass protocol, skipping the triage desk entirely and moving straight through the trauma doors. They are immediately wheeled into the Resus, or resuscitation area. This room is staffed by attending physicians and nurses trained in advanced cardiac life support, a set of specialized clinical protocols for treating urgent cardiovascular emergencies, and surrounded by heavy life support equipment. Medical professionals operate under the concept of the golden hour, the critical 60-minute window after an acute illness or severe injury, where rapid medical intervention significantly boosts survival rates. Bypassing standard intake procedures to reach the resuscitation room immediately is the single most critical factor in hitting that window. For patients who are seriously ill but not in immediate seconds-count danger, the system routes them to an area known as majors, or acute care. This includes people suffering from severe abdominal pain or complex neurological issues. This animated floor plan tracks a patient moving from the triage desk directly into a central majors hub. They are placed here because they require close physical proximity to advanced diagnostic testing, like CT scans. A CT, or computed tomography scan, takes a series of X-ray images to create detailed cross-sectional views of the internal organs. Further down the urgency hierarchy, the floor plan routes patients into a separate minors, or fast-track wing. These patients have non-life-threatening conditions, like fractures or lacerations requiring stitches, allowing for a much faster entry to exit cycle time without tying up the complex routing in the majors hub. The department also utilizes highly specialized routing zones for sensitive cases. Psychiatric patients are directed to dedicated safe rooms, and pediatric areas often employ play therapists to reduce the severe anxiety children experience in hospitals. By physically dividing the department into these specific zones, the hospital ensures that resource-heavy diagnostics and specialist teams are reserved strictly for complex cases, while minor injuries are treated without clogging the facility's main arteries. When you look back at that crowded waiting room from earlier, viewed through the lens of the triage matrix, the entire environment shifts. It reveals a central paradox of emergency medicine. A long wait time is not necessarily an indicator of a broken or inefficient hospital. If you are left waiting in a plastic chair for hours, it is definitive proof that medical professionals have evaluated you and deemed you medically safe. The system is forcing you to wait because it is prioritizing the resources required to keep someone else alive. While the triage funnel manages the flow, the human pressure on the staff remains absolute. In a department defined by rapid prioritization, doctors must make definitive life or death calls in seconds, often for patients they have never seen before. In this high-velocity environment, the penalty for missing a hidden catastrophe is so high that it creates a cycle of over-testing. Doctors frequently order imaging scans and blood tests for minor complaints just to be safe, a defensive strategy that ultimately drives up the total cost of the healthcare system. Triage imposes cold, life-saving logic onto the unpredictable chaos of human emergencies. It is an unsung system designed to guarantee that, when the absolute worst happens, the right medical resources are deployed at the exact right moment.